Good afternoon, everyone. I'm Dr. Gentili, Wright State University, and I welcome you to this training. This is Medical Assessment in Intellectual Disability. I thank you for taking time for being at this training. It's one of my favorite topics, actually, to look for medical conditions in individuals with ID, and I'll just use ID throughout the presentation to represent intellectual disability or intellectual and developmental disabilities. I want to take a moment and just a couple housekeeping items. We do have a chat box, so if you have questions throughout the presentation or comments, we welcome those, and you can enter those into the chat box. And Megan Patrick will be our coordinator today, and she will be helping us at the end of the presentation to go through those questions. Also, there was an issue with the CEU, the numbers that we need to give to you. So what we're going to do is, as soon as we get those from the Ohio Department of Mental Health and Addiction Services, then Megan will actually be emailing you those numbers, and then at that point you can then take your survey and the knowledge check, and you will get your CEU. The credits will be administered to you at that point. So sorry about the delay, but we will get those to you ASAP. And I just want to thank the Department of Developmental Disabilities and the Department of Mental Health and Addiction Services. Both of these state departments have been incredibly supportive, and they are responsible for the availability of this training and the others that we've been doing throughout the Tuesdays this summer. We're actually going to be doing these into the fall as well, so stay tuned and for the announcements on various topic and content areas, and we welcome you to these trainings. The trainings will also be there's an e-academy on the website for Mental Health and Addiction Services, and these trainings will be submitted and available to you on e-academy if there's people that are not able to attend in real time for the live sessions. So that being said, let's get going, and we will be just briefly, my disclosures. I don't have any conflicts of interest. I don't have relationships with pharmaceutical companies, even though sometimes I will mention some medications with regard to patient scenarios. And those patient scenarios are all fabricated. So any resemblance to real patients is purely coincidental. Okay, now these are our objectives for this training. So at the end of the training, we want you to be familiar with behavioral presentations of patients with ID and how to determine the etiologies. So that's where the detective work comes in, and that can be time consuming. It can take a while. We may need to pull in other multidisciplinary members to help be on that team, but we should always be able to create a treatment plan and come up with an accurate diagnosis for our patients. We also want to know the most common medical conditions that are underdiagnosed or undertreated in patients with ID. And we want to understand what diagnostic overshadowing is, and also the nuances of prescribing psychotropic medications in this specialized patient population. So on the next slide, I've got these 4 different statements, and these are in order for a specific reason. We want to go through 4 areas here. So medical comorbidity, so someone with ID who also has a medical condition, and which is really common. It's more prevalent in every organ system, so lungs and heart and the musculoskeletal system and the central nervous system. So if you go through every organ system in an individual with ID, they're more likely to have medical conditions in each of those systems, unfortunately. So it's even more important for us to be screening for those and to address the medical conditions. Also, trauma history is thought to be as high as 90% in patients with co-occurring conditions, and we'll talk a little bit about trauma and how that's a piece of medical wellness and in identifying medical conditions. Losses and other extensive change are more difficult to process for individuals with ID, and we'll be talking about the developmental stages wherein an individual lives, and so that we can see or experience the happenings and the occurrences in their life from the developmental stage in which they live. So this is the formulation. You may have seen this before, and I won't read this verbatim to you, but the biopsychosocial formulation was identified by Dr. George Engel in 1977. And for individuals with ID, I like to add that fourth piece, that developmental piece. So this is a gathering of information. So we might go through medical records and we might interview interested others, family members, caretakers, and we may talk to collaborating agencies. So the goal here is to address and understand the developmental needs of the individual in a meaningful way, and to use trauma-informed approaches and trauma-informed care principles as a universal precaution. So that's the goal here in identifying behavioral issues and in linking people with the resources and services that they desperately need. So these are the biological aspects. We want to know demographic data. Just this is a 14-year-old female with history of schizophrenia. And so just sort of a basic thumbnail sketch of the patient. And then medical comorbidity, are they already diagnosed with any medical conditions? And are they being addressed by a healthcare provider at that point in time? Also, it's important to know genetics, if we know some things that run in the family, other family members who may have mental health conditions or who may have intellectual disability or other developmental conditions. And I always love to have a complete medication list, and that's past and present. That gives us a lot of information so that we can make clinical decisions to help the patient to function at their highest level possible. And so if a medication was tried in the past and the patient had side effects, for example, or the patient is currently taking medications, we need to know all of that information. If it's in a timeline in order, that's even better. And for example, if a medicine caused a seizure disorder, or if the patient had a tremor, or if the patient was hospitalized soon after a medication trial, those are all really important pieces of information for us if they're available. And also substance use, if there's any substance use history or treatment in that area, that's also important for us to know. So about the biological aspects, when we're looking at the 30,000-foot view with medical conditions in ID, about 85% of individuals in one study had untreated or undertreated or underdiagnosed conditions. And so you can imagine with managed care practices, with appointments that last 8 or 10 or 15 minutes, these conditions worsen, and this number will go up precipitously when people are in their health care provider services and they have a 10-minute appointment. It's really not possible to work well within that kind of system. So we have to order lab work. We have to do a physical exam. We have to make sure that the patient, if the patient has an OB/GYN problem in that umbrella, then we should link that person with that correct resource. And we also can see in this patient population that medications are sometimes used in ways they never were intended, maybe unsafely, or maybe without lab monitoring or other protocols like an Ames test, an abnormal involuntary movement scale test, for example. So we want to collect more objective data, because we will often have less subjective data. If the patient isn't able to come into our office and, for example, explain their symptoms to us or describe what they're feeling, especially if it's pain or discomfort, then we need to get more objective data, maybe more imaging, maybe an MRI, X-rays, and of course, if we draw lab work, if we draw some blood, we can rule out dozens of conditions with just one lab draw. So the chief complaint is often aggression, and in our practice, we probably have 90 to 95% of our patients referred to us in the initial gatherings and the initial meetings and appointments. There'll be some form of aggression, whether it's verbal aggression or sexual aggression or property destruction or self-injurious behavior. And so Sigmund Freud said all behavior is purposeful, and that's what we want to keep going back to, is to remember that what is the patient trying to communicate to us? And there's always important information in that realm. So these are some of the causes of aggression or other behavior change, for that matter. So maybe the patient is frustrated. Maybe it's something they're copying from another individual, a learned problem behavior, for example. Maybe they're in pain, and that can be physical pain, it can be psychological or emotional pain, or it could be an acute medical condition. So we always want to remember it's a means of communication. So that's one of the most important things. And then we go from there, biological, psychological, social, and developmental. And we'll go through each of these in some detail. So these are some of the commonly missed medical conditions. And they're not in any specific order. These are just the ones that we have seen most frequently in our patient practice. And we have a telepsychiatry project, as some of you may be aware of, and we have about 2,400 patients in that physician practice. And we have engaged those patients from 86 of the 88 counties in Ohio. So we have sort of a nice cross section of patients wherein we can start to collect data and then share it and to create this pyramid effect. So we can share that information and hopefully help the psychiatric and the medical care of our patients in all areas. So seizure disorders, we see those a lot in our patient population. I've seen statistics 35 to 50%. And remember that there's lots of different kinds of seizure disorders, and some of them can present with aggression. So that's important to note as well. So physical and emotional pain, and of course that can have dozens of causes if you look at those two categories. The lungs seem to be a system, an organ system wherein there is some vulnerability in this patient population, unfortunately. And the dysphagia, that's trouble swallowing. And infectious diseases, that's abbreviated there, that's upper respiratory and lower respiratory conditions. And then I won't read through the rest of these, but remember that we also don't want to miss allergies, whether they're food allergies, environmental allergies, medication allergies, and we often miss these and they go unnoticed. We'll talk a little bit more about what we might do about that, sort of an action plan. So I have a couple slides in here about medications. And so just some general guidelines. We want to start low and we want to go slow. This is what we do with the pediatric patient population and the geriatric patient population. This is the same thing that we should be doing with our ID patient population. So remember that we don't have specific best practices and we don't have specific evidence-based medicine principles for patients with ID. So unfortunately, we're working toward that, but we're not there yet. And so the best thing to do is to use best practices for the general population and apply those and be more conservative. In other words, starting with lower dosages and moving up the ladder slower to increase dosages to make sure people are safe and we're catching side effects. Benzodiazepines are medications such as Klonopin and Valium and Ativan, and these might cause an opposite or a paradoxical reaction in patients. So a medicine that's supposed to cause someone's anxiety to decrease, they may find that they become agitated or they become aggressive. They can become disinhibited. And so that's something that we want to watch out for in patients. Or sometimes I ask the question, has the patient ever been given medicine before a procedure or before a shot or before an appointment and the opposite happened? Instead of calming that person down to attend the appointment or to undergo the procedure, did they become angry or irritable or agitated? And we want to document that in the chart. Patients with ID are more vulnerable to all side effects, unfortunately. So the metabolic side effects include things like blood sugar increasing, cholesterol increasing, weight gain. Those are all metabolic changes in our bodies. And then EPS, that is extrapyramidal side effects, and those are the movement disorders. The patients with ID are more vulnerable to tremors and to movements of the head and neck area, the tongue especially, and the irreversible EPS is tardive dyskinesia, or TD. We do have some medications to treat that, but we want to be really careful with prescribing antipsychotics and really careful with dosing and to be monitoring patients at least every 3 months to be watching for a tremor or shaking or other signs that maybe they're not tolerating that medication very well. Using timelines, I already mentioned, I think that's really important, and it's been incredibly helpful to me in making clinical decisions. And also we want to just make sure if someone is over-medicated, they're very likely to have memory issues and sedation, and we don't want to go in that direction. These are also some other options for patients if they have agitation or anxiety or obsessive thought processes or compulsive behaviors. The opioid agonists like naltrexone, this can be helpful for the symptoms I have listed here. It's not for everybody. We have to look for side effects with every medication, but it can interrupt the reward system in the brain or the central nervous system so that a repetitive behavior or repetitive movement isn't so satisfying for the patient. And so it can help sort of tamp that down and decrease impulsivity. Beta blockers are just great because they're great anxiety medications, especially in patients who have had a traumatic brain injury. And the next category, that alpha agonist category, those are medications that can help with ADHD symptoms. So even if someone's not diagnosed with ADHD, they may still have some attention span problems or impulsivity or some irritability. And then the stimulants can also be helpful for ADHD. And atomoxetine is also called Strattera, and that's a non-addictive, and it's not a Schedule II medication, so it's easier to prescribe and easier to access, and that can be really helpful for individuals who need a little help in the attention span and impulsivity area. Okay, so dysphagia or swallowing problems are also more common in patients with ID, and it can lead to patients not wanting to take their medications or non-compliance or non-adherence. I like to give patients, if they're taking something twice a day and we want it to optimize that medication during the waking hours, I like to do an 8 a.m. and a 3 p.m. dosing administration instead of AM and bedtime, for example. We don't need some of these medications peaking at 2 or 3 in the morning. And if we're giving people some of their medication at 9 p.m. or 10 p.m., when we actually want it to be working during the daytime. Sometimes patients can be helped not by a dose increase, but by just changing the scheduling and the timing. We also want to be careful with meds that change seizure threshold, and there are a lot of them. Doesn't mean we can't use them. It just means that we have to use extra caution in someone who has been diagnosed with a seizure disorder, and this includes Wellbutrin, clozapine is another one. Cogentin is an anticholinergic. Antihistamines, which a lot of us take for allergies. And again, it doesn't mean we can't use them. It just means we want to be cautious about starting them, and we want to be cautious about any dose increases. In NAC or N-acetylcysteine, this is another one that's been used in more recent years, and it can really be this, it's an over-the-counter, it can be helpful as an adjunct for irritability, for aggression, agitation, for skin picking, and it can also limit polypharmacy if we have families or individuals who would rather not add another prescription medication. NAC can be an adjunct that can be really helpful to tamp down some of those symptoms. So these are some other medication cautions. We talked about polypharmacy. We want to really move away from that for so many reasons. And autism, individuals with autism spectrum disorder diagnosis, they can be more vulnerable to balance problems or ataxia if they are receiving a benzodiazepine. Not all of them, not all individuals with autism, but some of them. So it's another thing we want to be screening for really carefully. Individuals with fetal alcohol syndrome or symptoms in that category, they can experience reduced effectiveness if they are taking ADHD medications. So sometimes with those individuals, we'll move to like a second line or a third line treatment for ADHD. There are a bunch of documents out. There are expert consensus guidelines. Since we don't have best practices, we want to just use solid decision making, but we can also refer to these expert consensus guidelines, and they can guide our decision making. And these were authored by experts in the field from all over the world. And so it really is a nice compilation of important information for us. Okay, I am going to just quickly mention these cases and move on because we have a lot of slides to get through. So this is a 16-year-old female who was seen in the emergency department with no mental health history. And we do know that transition age is a time in life where mental illness, mental health symptoms are more commonly presented for the first time, and it's also a time when they can worsen because these transition age years are very difficult for individuals. So this individual was refusing to eat, was aggressive toward others, so a lot of externalized behavior, and appeared to be paranoid. So this was a rule out schizophrenia, and our group was called to do an assessment and to get this individual integrated into our clinic very quickly. And the mom took the patient home, and the appointment was just a day or two later, but the patient was not eating and was not drinking. And so that indicates to us that there's a medical problem here. This doesn't sound purely like a psychiatric issue. So we weren't ruling out the fact that Crystal had some mental health issues, but we were ruling out the fact that the acuity or the urgency of this case needed to be in the hospital, inpatient. And so Crystal ended up going back a couple times, and finally they did a physical exam and they did some blood work, and they found that she had esophageal ulcers, which is a very painful condition and not at all related to mental health. And so she didn't actually have a mental health diagnosis, and was actually treated inpatient for a few days. But we should look for signs. If someone's refusing to eat and drink, then there's probably some discomfort or some pain involved in that. Bobby was another patient that we treated and we diagnosed. He had a history of autism spectrum disorder as well, and 4 months of agitation, aggression, kicking, and also self-injurious behavior. He had also lost about 13 pounds in that 4-month period. So that's notable and should be investigated. And so we did the Bio-Psycho-Social-Developmental Formulation, and Bobby was seen, again, with the appetite, the weight loss, which is significant, and trying to consume pieces of blankets, pieces of napkins. He was trying to comfort himself because he was in pain. So when someone who does not have a history of pica is eating pieces of blankets or sheets, then it sounds like a GI problem. And he was seen by the GI specialist, and he did have a volvulus, which is a part of the colon that's twisting and untwisting, and it's a really painful condition. He did have to have a resection, and he also had some family interpersonal issues. Mother had passed away also, which sort of started this whole thing off. But he was actually treated with a surgical resection, and he was able to return home to his supported residential setting, which was a group home with the same staff for many years. So that was a reasonable outcome for him, and he was able to navigate with that resection post-surgical. So let's go system through system. I think it's important for us to make sure we're paying attention to the heart and the lungs, and here we're going to start with, I've combined here for you cardiovascular, the heart system, with metabolic issues. And metabolic issues, it's sort of a broad term, but we're really talking about sodium levels, electrolytes, and when you have a lab panel, sort of a comprehensive metabolic panel, it's going to take a look at your liver and your kidneys and your blood count and some other things. So these often will happen, cardiovascular and metabolic, at the same time or in combination with each other. Unfortunately, for the patient population, this is the most medicated population. It's been described in the literature. And that, again, refers back to the polypharmacy, which we really need to address and get rid of. So primary care physicians are less likely to recommend preventive care or maintenance care for patients with ID. And that's another thing that we absolutely have to address. So there were some studies that came out several years ago, and one of them showed that if someone has a severe mental illness, then their expected life, their life expectancy is much less by about 20 or 25 years, actually, if they have a severe mental illness. Individuals with ID who also have a co-occurring mental health condition are even more significant with less expected life. So it's really important that we keep people healthy, that they are doing their preventive care just like the general population. Now, what are risk factors for coronary artery disease or heart attacks. Well, I like to divide these into two separate categories. So there are some that we can modify and there are some that we cannot. So the ones that we cannot change are our age and our family history. So you can't run from your family history, and neither can our patients. And so those are important things to know. If you have a significant family history for heart attacks, then you should have a different screening protocol. It should be earlier and more often. And what are the modifiable, or what can we actually change? Well, if someone's sedentary, if they sit a lot, they don't do a lot of exercise, that can be changed for most individuals. Of course, our individuals with ID may have mobility issues, they may have physical conditions that limit them from certain types of exercise, and we'll talk about that as well. But smoking, that can certainly be changed, and high blood pressure, high cholesterol, those can be treated. You may not eliminate the diagnosis, but if you are in active treatment and those are stabilized, then we consider them changeable or modifiable. Obesity and diabetes. So these are all the things that we can change or at least address with proper medical treatment, and we want to make that available to our patient population. We will, again, have lack of subjective data in many instances. We talked already about the side effects and how our individual patient population will be more vulnerable to side effects and to extrapyramidal side effects. And if someone has limited mobility or they can only do certain types of exercise, it can make the metabolic side effects even worse. So those sort of add together to be a bigger problem. So reasons for higher risk. Sometimes we have patients that have difficulty understanding the information that we're giving to them. So that's why the team is so critically important. People on the team to help abide by guidelines and to inform the patient and explain it in ways in which they will understand, because we want people to be invested in their care and their health and their well-being. That just makes for better outcomes. We also have a lack of trained staff and caregivers often, and especially in the context of the pandemic, and we've all been struggling with staffing issues. And also we want to remember that exercise issues are, they're more complicated by definition, because if you look at the availability of exercise programs and weight loss programs, they're not necessarily designed for individuals with ID. And also we think individuals with Down syndrome, they're at higher risk in those areas as well. A minute just to talk about smoking. This is really important, because if a healthcare provider talks to an individual, or if a caregiver talks to an individual about their smoking, they're more likely to quit. They're more likely to think about it. You're putting it on their radar. It's got to be a respectful conversation, and we tend to use motivational interviewing, and that's where we will ask the individual, what would be the advantages of you cutting down on smoking cigarettes or quitting cigarettes? So hopefully they'll come up with things like, I would have more money, or I would feel better, or I wouldn't get bronchitis, or I wouldn't be in the hospital with pneumonia every winter, things like that. So motivational interviewing means you get buy-in from the individual that you're trying to influence. Diabetes, we should talk about this because unfortunately there's a higher prevalence among individuals with ID, and this is a complicated illness. Diabetes affects or can affect every organ system. And it's also more common in those who have seizure disorders. And it's also more common in individuals who are taking anticonvulsants or mood stabilizers. So there was a statement released in 2019 that individuals with ID, and this is from the American Diabetic Association, that they have specialized needs and they have multiple nutritional concerns. So that's something important to keep in mind, that it's at the outset, it's just going to be a more complicated illness to navigate. Okay. And onto the respiratory system. So when we look at respiratory conditions, they are overrepresented in the ID patient population. So one study found that they're more common in individuals who have cerebral palsy and who have suffered a traumatic brain injury. And those are the two of the populations that are at the highest risk. So if you have difficulty moving or if you have decreased movement, then you typically will have poor airway clearance. So you may not be exhaling all of your air. So you'll have a larger residual volume of air in your lungs after you exhale. That sets an individual up for infections like pneumonia, like bronchitis, like sleep apnea, which is incredibly common in our patient population. So we have to be screening for these, and we should do screening earlier and more often. That should just sort of be our MO with all of these conditions. GI symptoms. So this system has lots of different conditions, and a lot of these are more common in ID. Reflux disease is one of those, incredibly common. In fact, in one study, they were comparing individuals who were living in the community dwelling, and they were comparing them with individuals who were living in institutional settings. And 50% of individuals with IQs of less than 50 had reflux disease, whether it was treated or not, or whether it was fully treated or not. And this is something that's painful and it's uncomfortable, and it can cause other problems if it's untreated for long or lengthy periods of time. So the recommendation from the group was that physicians should have a low threshold for using medications or prescribing medications that can treat reflux disease, so to lower the acid. And there's two groups of medications. We have our H2 blockers, like Pepcid, for example, or Tagamet. These basically just neutralize the acid that's already in the stomach. And then we have stronger medications, which are called proton pump inhibitors. These are the medications like Prevacid and omeprazole. And these actually shut down the pumps in the lining of the stomach that release the acid. So it sort of stops the acid from being put into the stomach in the first place. Whereas, like I said, the H2 blockers, they're weaker, they're strong enough for a lot of people to eliminate and fully treat reflux. But it sort of depends on if it's a minor problem or if it's a more serious problem. The proton pump inhibitors are going to be stronger, and they're going to shut those pumps down. Okay, so GI bleeds. These are unfortunately more common in individuals with ID as well. And so they're complicated because if someone has an increased threshold to pain, if they have difficulties communicating their discomfort to others, then it can become a more serious issue as opposed to catching it early. Male gender and history of pica are the highest risk groups. And also, one more thing I just wanted to add here is H. pylori. H. pylori, or Helicobacter pylori, is a specific kind of bacteria that exists in a lot of our GI symptoms. So a lot of us have H. pylori in our system, but it's not causing problems. In individuals with ID, H. pylori can cause significant problems. It can start with pain, it can cause ulcers, gastric ulcers, peptic ulcers, and in individuals with ID, the prevalence is 2 times that of the general population for causing problems. And if it's treated, it will recur at a rate of more than 7 times the general population. So this is something that if someone's having abdominal discomfort or abdominal pain, or they're having a workup for some kind of GI symptom, then H. pylori would probably be a good lab to add to that list to make sure we're aware if someone has it in their system. So let's move on to menstrual related conditions. We do know we have some prevalence data on breast and cervical cancer screening, and there's a lot of inequality when you compare the general population to the ID patient population. So 11% of women had no documented GYN visit in this study. This is from The Ohio State University, Dr. Haverkamp, and almost 27% of women with ID over age 40 had no documented mammogram. So this must stop. We can't ignore preventive protocols when someone has ID. We should actually be doing things earlier and more often. This is another study where 90% of caregivers would approach healthcare providers to suppress menstruation. And so, and 40% of these were actually before the the female had even started menstruating. So the concerns here were hygiene concerns, trouble coping, as opposed to using birth control, for example, to regulate menses. So when some of these studies were done, there were actually very few options in this category, and now there are more. That has definitely expanded, which is a good thing. So we just want to be sure that when family members or caregivers are presenting to healthcare providers and they're asking to either regulate menstruation or stop menstruation, we want to be careful not to miss medical conditions. And we want to explore that request. So does this person need to have menstruation interrupted? For example, are there baseline bowel or bladder incontinence issues? This is always complicated by pre-existing dependency needs with activities of daily living and bathing and showering, etc. Privacy issues, hygiene issues. So there's a lot of layers here. And so this should be a careful discussion by the healthcare provider to make sure they're making good decisions on behalf of the patient and also not missing things or abbreviating protocols. So we don't have standard or any consensus of sorts on how to meet the needs of individuals with ID who have menstrual related conditions. Again, we're just going to use the protocols from the general population, and we're going to nuance them or use subtleties to apply them to patients with ID. We do have some stats on Depo-Provera and other injectables. These can suppress menstruation. I have here for you the mean or the average age of the first menstrual period. It's a little bit later in individuals with cerebral palsy, just of note. Okay, and now this is basically looking at with menses where there can be aggression, agitation, self-injurious behavior. So it is a fact that about 80% of women who are menstruating have varying degrees of premenstrual symptoms of some kind, whether it's bloating, whether it's headaches, whether it's cramping. So 80% of women. So I think this is something that we probably miss very frequently in the ID patient population. So monitoring for periods and charting them and asking individuals, I mean, if you're noticing behavior change prior to menses or during menses, we have to keep in mind that those hormones are fluctuating wildly during that menstrual cycle. And so we don't want to miss these things. So NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen or Advil, they were effective for about 65% of the females menstruating in this study. And oral contraceptives were effective for about 40%. Depo-Provera's numbers are pretty impressive too, which just sort of decreased the degree or the severity of the PMS symptoms that women were experiencing. So that's important. We don't want to miss menstrual-related conditions. They can just be incredibly uncomfortable. Okay, so this is these are some stats on cancer, just some general statements. So colon cancer, it's about the same prevalence when you compare to the general population versus ID. And breast cancer, slightly lower if someone has a parity issue, if someone has had a child, and if someone has breastfed a child in the past, that also impacts prevalence and typically decreases women's prevalence of having breast cancer. Also, cervical cancer is typically related or usually related to the number of sexual partners one has had and to the frequency of sexual activity. So that will impact the numbers, general population versus the ID patient population. And luckily, there's a lower prevalence rate of prostate cancer that was shown in 2 different studies, but we still recommend the same screening protocol until we have more data. So we wouldn't want to eliminate preventive protocols looking for prostate cancer or getting the PSA and checking that for male individuals with ID. So osteoporosis, unfortunately, our patients with ID have an increased prevalence. and it's not limited to postmenopausal women. Women that are going to be more likely to develop osteoporosis are going to be smaller frame women. Caucasian women are at higher risk. Women who don't do weight bearing on various bones. It just sort of depends on how active you are and what kind of activity you're involved in. These are some studies that identified high risk groups. And so inactivity, which we knew from the general population, if someone's using or has taken anticonvulsants for long term, which if someone has a seizure disorder, there's not much we can do about that. Down syndrome questionably had a higher prevalence of osteoporosis, and anyone who has low vitamin D levels. So that's a vitamin we want to track, especially as people age, and make sure that we're replacing it if the vitamin D level comes back low. And that's especially important for states where we have seasons, where we have winter, and we have months where we don't get as nearly as much sun exposure, for example. And then I always like to say that it's important to know several syndromes and the details about those syndromes. I read about syndromes on a regular basis because if you know what medical conditions are more prevalent related to those syndromes, then you can be screening for them more thoroughly. And if you know what their cognitive capabilities are, specifically for Down syndrome or Fragile X or Angelman's or other syndromes, then you're able to more effectively treat a patient because you know it will help your communication patterns with that individual. I will change my lab screens for these individuals based on an identified syndrome. So there's lots and lots of benefits to this information. So these are the stats for individuals with Down syndrome, and they do have a shortened life expectancy versus the general population. And we know that hearing impairment is common. They often have mid-phase anatomical abnormalities, which affects their vulnerability to develop respiratory infections. They often have enlarged tongues, which can also affect their speech and communicative ability. Some of my patients have had tongue reductions because of that, which can be very helpful. This is Fragile X, same sort of slide. You can read the stats here. One thing I do want to mention is FXTAS, which is Fragile X Tremor Ataxia Syndrome. So this is a syndrome that basically we have problems with thinking and with movement. So it's usually later onset after age 50. It affects males much more frequently than females. The symptoms worsen with age. Patients will usually have high blood pressure. They'll usually have balance problems. They can have tremors. They can have seizures. Thyroid problems and muscle pain are all very common. Okay, so basically primary care and preventive care. So we know that our individuals with ID may have unusual or atypical presentations when they go to a primary care physician. The evaluation of a patient with ID should be similar to a patient who has some memory issues or delirium. Concentration problems, attention span problems, memory loss problems. So there can be a lot of detective work. It can take a longer amount of time. So that could mean longer appointments or more frequent appointments. It can also mean more lab work and imaging, which is the route that I go very frequently. This was a task force that was really helpful, and they considered evidence-based practices and accepted those as a standard of care. So this is the word that we need to be spreading so that people get the thorough physical exams that they need and deserve. These are labs to consider. This is not a list of labs for every single patient, not by any means. So you really have to know your patient. You have to depend on patient history, on family history, on what are the presenting symptoms, and many other factors. So just remember, we want more objective data when we have less subjective data. So this is just a list of labs that I have utilized with a variety of patients, but very few patients I will order all of these labs for. Again, one lab draw can eliminate dozens of conditions, so it's so helpful. I'm not going to read through all of these just in the interest of time, because we have a few more slides to get through. But if someone is rocking, we just don't want to consider that being normal. We want to look for abdominal pain, which is your viscera, is the internal lining of your abdomen. We want to think about headache syndromes, depression, and anxiety. If someone is biting a hand or a fist, we want to think about, first of all, think about the two body parts, the oral cavity and also the hand. So they could be applying pressure to something that hurts. It could be reflux disease. It could be a sinus infection, asthma, ear infections, or otitis media. Also dental problems. And I also think we should have a low threshold for that panoramic x-ray when we think that there could be an oral cavity medical condition that has not yet been discovered. If someone won't sit down, these are all of the medical conditions we should be thinking about. Akathisia is a medication side effect that is completely reversible. People have this restlessness and just need to move, and this is usually caused by an antipsychotic medication. We don't want to assume that this is psychosis and just bump up that medication. It makes it worse for the patient. If someone's whipping their head forward, then we should be thinking about that instability of the cervical spine area. And this is really common in individuals with Down syndrome. And they also can suffer from just joint laxity in other joints in their body. But also think about dental problems and headaches. If someone's banging their head, first thing that I think about is depression, anxiety, or trauma. And so we want to rule out these conditions to make sure we don't miss something, but we don't want to consider it normal. So the key to success for medical and biological conditions, in my opinion, is preventive care screening, making referrals when we need to involve other people on the team, and really sticking to best practices in evidence-based medicine whenever possible, and then adapting it in a safe way for our individuals. So the psychological part, we're just going to run through the rest of these three areas really quickly. We just want to make sure that we are in tune with the patient's communication abilities. So we want to know that going in, if there are medical records to review, if you have that triangle in the room, that triangle of the healthcare provider, the individual, or the patient, and then a caregiver, for example, you want to talk to the patient. We don't want to just talk to the caregiver or the provider. Of course, that person has incredibly important information, but it has to be a triangle where all of the parties are important. And if I am questioning it, if I'm getting accurate information from the individual, then I'll ask questions in a different way. Or I'll do cross-questioning, for example. So I'll phrase things in a different way. And if there's a mistake in the communication, I'll just own it and apologize and then move forward. And remember, there's no plug and play for communicating with individuals with ID. We really need to just practice, and the more patients that we see, the better we'll get. This is an important slide because what if the patient doesn't have usable language? So what if they're nonverbal? There's still so much information that we can collect, and this is just a short list of those things, and it goes on and on. So these are some specific interview strategies, and I'm going to skim across these for you. We want to use time anchors that matter to the patient. So not time anchors that matter to us, for example, may be more helpful. It may expedite filling out our documentation. But if we use bowling night or a holiday, we're likely to get better information from the patient. Acquiescence is when the patient will tend to agree with statements that an interviewee has given. We want to be cautious and aware that many individuals that I deal with and that I treat and provide care for will have been told, ignore that if they're upset about something, or don't cry. And I always think, what message is society giving them? That their emotions are bad, keep them in, don't communicate what you're feeling. And we really need to combat that. We need to help people move to a place where emotions are not problems. Emotions are signals, and we should be able to talk about those in a healthy way. So it is a myth that you can't get good information from the person with ID. There are ways to ask higher yield questions, so we want to be aware of that. But everybody might have difficulty recalling an event that was 7 days ago or 60 days ago, communicating what happened, coming up with details of names, places, people, etc. So we have to ask in a creative and artful way, and we will get there. Subvocalizations this is sort of a really interesting phenomenon, and patients with ID will be practicing their response before delivering it often. And so we do this too. Everyone that is communicating with words, if you are asked a question, you will typically practice or plan what you say, especially if it's someone that you don't know very well, if it's an acquaintance, if it's someone you're trying to impress, you'll sort of practice quickly in your head what you're going to say, and then you deliver it. So subvocalizations in ID will look a little different. It may look like they're stalling, or they're pausing, or that they're being adversaries, and that's not at all the case. They're actually practicing their response before they deliver it, and so we should be able to distinguish that from those other options. So these are some other interviewing techniques, and saliency is just sort of the importance of your words. So if you talk about something that the patient cares about, you're much more likely to get more information and more accurate information. So saliency of common events may be greater for individuals with ID, maybe going to a restaurant to eat food. That's something that they will remember that was very important for them, and it will help bring back memories related to that. So what works? These things work. These are the most effective ways to, first of all, to build a therapeutic alliance and build a relationship with patients. Summarizing, clarifying, recapping, paraphrasing, so important. The patient will know that you are listening, that you are paying attention, and also if you have a therapeutic alliance with that patient, if they trust you, then when you summarize for them and you haven't gotten it quite right, then they'll feel comfortable in telling you that. So this is another group of slides that I love, and I think they're really important, but we don't have to read through them necessarily. This is just letting us know that you have to observe attention span, impulsivity, any motor movements, personal space. Take your time and plan that an interview or a conversation will take more time. And then alter your interview verbiage. And here are just some examples of ways that we may want to phrase questions if someone has moderate or severe ID, for example, to get accurate information so we really know what's going on. And then these are some possible indicators of not medical conditions, but psychosis. So if someone's wearing multiple layers of clothing, but remember the medical piece is that could be because they have thyroid problems, or they have medication side effects, or they have hormonal changes. So that's why these are related to the medical conditions and that theme. What if they're covering their eyes or their ears? Sometimes in psychiatry, we'll immediately think, okay, they're hearing voices or they're seeing things, but it can also be an expression of hypersensitivity. The noise is too loud, the light is too bright. It also can be pain and depression. And self-injury is very important. It can be, this could be related to psychosis, but it's usually not. It's usually explosive aggression, something the individual can stop or start with volition or at will, and self-talk is usually not psychosis. So the key to success for psychological, this piece is always take a trauma history, and sitting in the chair just means being with the patient and connecting with them and letting them know, messaging to them that you care and you want to hear their story. And this social piece is definitely, this is multifactorial. It's just basically looking at where is the individual living? Are they going to school? Are they achieving goals? Do they have people? In other words, do they have peers? Do they have siblings? Do they have grief and loss issues that are not yet processed, or trauma that needs to be addressed? Do they have a lack of control over every piece of their life? These are all important in our social functioning, settings, programming, routines, structure, and having an inner circle. Everyone needs an inner circle. Remember that the team has to be built around the individual. So these are all individuals or or people with different skill set that we may involve on the team depending on what the individual's needs are. And then finally, the developmental piece, which really is when you study the different stages of development, and Piaget is my favorite theorist, then it gives me good information about how will they be looking at loss, how will they be processing grief, how will they process trauma. And so I just have these in categories that you could read through and hopefully would be helpful. How do we talk to someone about loss if they have profound ID? How do we process grief if someone has moderate or mild ID? And so these are just some guidelines along those lines. So this is when there are signs that a diagnosis is incorrect, or maybe I've missed something. If someone's not getting well, if I'm using more than one med in one class, if someone has side effects and I haven't addressed that. So these are the 4 keys to success. It's so important to identify these medical conditions in patients with intellectual and developmental conditions. They are more vulnerable to mental illness. They're more resistant to they're more vulnerable to the side effects of psychotropic medications, both metabolic as well as extrapyramidal. We tend to overdiagnose psychotic disorders, and we tend to underdiagnose anxiety and depression disorders. And it's a myth that individuals with IDD cannot benefit from the full regimen of psychotherapies and behavioral interventions and state-of-the-art medication regimens. I want to thank the 2 state departments. They're amazing in that they support these programs and these trainings for the state of Ohio. And these are just, Ebony and Kelsey are point of contact individuals in the telepsychiatry project. If you have interest in referrals or second opinion assessments, or you have other needs. Thank you so much for your time and attention. It's truly been an honor being with you. Thanks for joining us and for all the important work you do. I also welcome questions and comments at this point.
All right, we do have just a couple of questions out of the gate. So referring to some of the examples that we had earlier on in the presentation, were either Bobby or Crystal nonverbal?
Yes, actually, great question. Bobby was. So the individual that had been trying to eat the pieces of sheets and the pieces of blankets, he was nonverbal. And Crystal was, she had some usable language, but it was very limited. That's often what we see with these undiagnosed medical conditions, unfortunately. So it's so important to do that behavioral analysis and the observational data and to have everything documented.
Okay, second question. My son is nonverbal and he cannot tell me when he is in pain. This is a very big concern because he does have health conditions. What do you suggest I do to find out?
Yeah, this is a great question as well. So you want to put some of these pieces together. So sometimes if I have patients that have come in and we have made signs together. So we'll sort of make a sign that means yes or means no. Sometimes I'll draw a picture and I'll point to different parts of the body and ask if anything hurts in that area of the body, in that part of the anatomy, for example. Sometimes I will get that extensive lab panel and I will find that there's inflammation somewhere, or I'll find that, oh, there's a white blood cell count increase, and so that indicates an infection. So sometimes I will study medical records, and whether that means an electronic health record system, whether that means hundreds of documents that people will send to our team. And so what you can do is, sometimes you can put patterns together. You can identify patterns that will recur in an individual. I have a patient that I am familiar with and have known for years, and I know that when she has a medical condition, then she will become aggressive, and there's typically property destruction involved. And when they call, the first thing I will say is, she commonly gets infections in her underarm area, the axillary area. And these are really painful cellulitis infections. And so the first thing I'll do is I'll order labs to get that red and white blood cell count, and that'll show that that elevated white count shows that there's an infection and an increase in neutrophils. and then I'll have one of the staff look under her arms and sort of do a quick brief check to see if there's redness, if there's swelling. And so sometimes there's a pattern you can go with, sometimes it's lab work, sometimes it's something else that you can observe. And sometimes you have to work with that individual, maybe with an app, maybe with an iPad or an app where you have identified, there are apps specifically for individuals who are nonverbal, and they can press on buttons to sort of communicate things to you. And I've had patients with some communication devices and apps and iPads come into my office or come to appointments prepped with some of that information so that they can communicate using technology. And technology has come, there's been a tsunami of research in that area, thank goodness, for over the last 5 or 10 years especially. And so there may be options available now that weren't available to you 5 or 10 years ago, even 1 year ago for that matter. So I would look through those 4 categories really carefully and come up with a list of ideas under all 4 categories. And then, by the way, we also do second opinion assessments, and so one-time assessments where we could go through this information and Ebony and Kelsey would be able to tell you more information about that.
I do want to acknowledge that there's a question about CEU surveys in the chat. I'm going to go ahead and answer that in text in just a moment. But we do have another question. It has been a struggle to find a provider to complete diagnostic evaluations for psychiatric concerns. Do you have any resources for this?
Yes, there's actually a nationwide shortage of psychiatry, and certainly in Ohio, there's a lot of counties in Ohio that have 0 psychiatrists. There's a crisis shortage of child and adolescent trained psychiatrists. So we feel your pain. I'm part of a training program. We're trying to increase the number of graduates each year, and we're certainly trying to recruit and retain people in Ohio. I think that I would probably, if you don't have someone in your local area that can meet your needs, then we do have some statewide resources, and the Ohio Telepsychiatry program is one of those resources. It's funded by the 2 state departments. We accept patients of all ages from all 88 counties. There's no restrictions. We bill Medicaid, so if the patient has Medicaid, that works really well. If the patient does not have Medicaid, we can definitely work around that because we have grant funding. But if you want to discuss options through this or other statewide programs, I would probably reach out to Kelsey Lorenz. She's our project manager, and you could email her, you could start a conversation, you could talk on the phone. So the telepsychiatry program is one of the statewide resources. The other one is the Coordinating Center of Excellence, and then also DODD has some resources listed on their website. So you could tool around on their website and try to identify, there's actually a regional liaison in each of the 4 quadrants of the state. You can go on their map and see who your regional liaison is, and they are incredibly educated and knowledgeable about all statewide and local resources. So I would definitely think about the regional liaison in your quadrant of the state, and or the DODD website, and or reaching out to Kelsey. Those would be my first suggestions.
All right, I did put some information about the CEU, the certificates in the chat there. Again, if you're joining us by phone, please go ahead and shoot an email to training.team@dodd.ohio.gov so we can add you to that email list. But I think that looks to be all of the actual webinar questions that we have for this afternoon.
Thank you so much to everyone for joining us and for all the important work you do. And thank you so much to Megan for all of your help as well.